chairman for the kind introduction, and I would like to also say thanks to the organizer for inviting me to join this interesting symposium. I'm given the topic of management of metastatic colorectal cancer. It is a huge topic. I would like to discuss it in the context of today's theme, precision oncology. Here's the outline of today's talk. I will first go through review some current management of the metastatic colorectal cancer. I will then finally I will discuss several local biomarkers and their implication in the management. What is personalized medicine? Personalized medicine, the whole idea is try to give the patient the best possible treatment, tailor-made according to their clinical features, according to their physiological status, and more importantly, in our era, is the molecular characteristics of the tumor. And when we look back, date back in year 2004, and at that time we have no targeted therapy, we have no widely clinical application applied biomarker. At that time, we have only limited choice. We have only FOLFIRI, FOLFOX, 5FU, and SILODA. At that time, JCO published a landmark trial. They randomized the patient either FOLFIRI followed by FOLFOX or FOLFOX followed by FOLFIRI. Basically, there is no difference whether which agent you use first, and the benchmark overall survival at that time is around 20 months. At that time, it's hard to say that there's any kind of precision in terms of management of metastatic colorectal cancer. At that time, it's indeed a one-size-fits-all approach. But in the past decade, we have a dramatic improvement in terms of the patient's outcome, in terms of our treatment precision, and also in terms of our treatment concept. First of all is the individualized approach. The two mostly implicated pathway in the management of metastatic colorectal cancer is epidermal growth factor receptor and also vascular endothelial growth factor. The anti-EGFR antibody, either cetuximab or panitumumab, they binding to the extracellular ligand of the EGFR receptor. Therefore, it blocks the downstream signaling pathway of the MAP kinase pathway, so that which is crucial for the oncogenesis, proliferation, and metastasis. On the other hand, bevacizumab and aflibercept is vascular endothelial growth factor receptor. By binding to the receptor, they block the pathway of angiogenesis, which is crucial for the tumor to proliferate. We now all know that WAS gene is very important in our daily management of metastatic colorectal cancer. The patients carry the WAS mutation, who is predictive of the patient to have resistance to anti-EGFR treatment. Initially, we only know that the patient with KRAS exon 2 mutation, they were resistant to the anti-EGFR treatment. Later, further studies suggesting that the less common WAS mutation, like KRAS exon 3, exon 4, or NRAS mutation, they were also predictive to anti-EGFR resistance. Here's a summary of trial that summarized the first-line chemotherapy plus EGFR inhibitor in management of metastatic colorectal cancer. Most of the trial, apart from the CON study, suggesting that in the KRAS wild-type patient, adding anti-EGFR antibody to the chemotherapy could improve the overall survival. And the survival improvement was more dramatic, was more pronounced in the patient with all RAS wild-type when compared to KRAS wild-type. Here's a busy slide, summarize selected phase 2 and phase 3 trial adding the bevacizumab Avastin to the chemotherapy. All show that adding Avastin, the vascular endothelial growth factor receptor monoclonal antibody to the chemotherapy, it would result modest improvement of progression-free survival and overall survival. Here's come to the next question, whether the EGFR inhibitor or vascular endothelial growth factor bevacizumab is the best biologic when used in couple with the chemotherapy. The first clinical trial tried to answer this question is, as Dr. O has mentioned, is the 5-phase study. They include around 600 patients with KRAS wild type. It is one-to-one randomization. Randomize the patient either receive FOLFIRI plus bevacizumab or FOLFIRI plus cetuximab. The primary endpoint is overall response rate. Initially restricted to the KRAS wild type patient in terms of response rate, it is a negative study. But the researcher later extended limited the study to only all RAS wild type population. It's find that FOLFIRI plus cetuximab is associated with better overall response rate and also overall survival, although there's no difference in terms of progression-free survival. The next study is the CALGB study. Try to answer this question. The difference between the CALGB study and 5-3 study is that it is larger in terms of sample size. Also, full Fox is allowed in CALGB study. It reflects the difference of the practice of United States from the Europe. Indeed, around 70% of the patients receive full Fox. And the third difference between CALGB study and 5-3 study is that the primary endpoint is overall survival. The conclusion is that there's no difference in terms of overall survival and also the progression-free survival. So here's a table summarized the two phase 3 head-to-head trial compared to biologic. As I said, CALGB is the largest study. Full Fox and also FOLFIRI were allowed, but not 5-3 only FOLFIRI were allowed. Primary endpoint CALGB is overall survival, but the primary endpoint in the 5-3 study is response rate. It's still a very debatable question whether why 5-3 study there's no difference in progression-free survival. But finally results are overall survival difference. There are several potential explanations, like the first-line treatment will affect the second-line efficacy, or there's a systematic difference between the second-line treatment in the trial. But in general, the overall international committee consider either cetuximab or bevacizumab can combine with FOLFIRI or FOLFOX acceptable first-line option. But in general, cetuximab is, the anti-EGFR antibody associated with better response rate, depth of response, and also early tumor shrinkage. Another point worth to note is that in year 2014, nowadays, the benchmark overall survival of the patient is up to 30 months, which is much better than day back in year 2004, only 20 months. This is not the end of the story. What is the recent couple of years have published a lot of data concerning the impact of the primary tumor location. Many research suggesting that the right side tumor is entirely different in terms of prognosis, behavior than the left side tumor. The JAMA Oncology published a paper involving huge number of patients, more than 1 million patients. It's find that right side in general is associated with poor prognosis than the left side tumor. It is independent of stage, independent of whether the patient receiving adjuvant chemotherapy. So the primary tumor location is prognostic. It's also predictive. The researcher in the CALGB study and the 5-3 study, they do a post-hoc retrospective analysis. It's find that in general, left side tumor is doing better than the right side tumor. For the left side tumor, usually the overall survival more than 30 months, but for the right side tumor, usually it's around 20-something months. And it's also find that for the left side tumor, seems that the anti-EGFR antibody derive greater benefit than the anti-vascular endothelial growth factor antibody. So that, but on the right side is different. Seems that bevacizumab derive greater benefit than the cetuximab, although it is less pronounced. Recently, there's a paper accepted by the Annals on Oncology. The researcher from the PARM and PIC do the same thing. And panitumumab, in fact, is also doing better in the left side tumor than the bevacizumab. And on the right side, bevacizumab also doing similar, a bit better numerically than panitumumab over the right side tumor. But a point I want to highlight is that when you compare the panitumumab plus FOLFOX versus FOLFOX alone, the left side definitely adding panitumumab seems better. But for the right side tumor, it seems that adding panitumumab to the chemotherapy does not derive many benefit. Numerically even detrimental. So nowadays we have quite convincing data suggesting that the sinus of tumor is prognostic. Patients with left side tumor have markedly better overall survival than the right side tumor. It is also predictive. For the patient carry right side tumor, it derives greater benefit from the bevacizumab than the cetuximab. And in the patient with left side tumor, they derive greater benefit from cetuximab than the bevacizumab. Here's the ESMO guideline. It's suggesting the ESMO recommendation suggesting that we should tailor our treatment goal. We should tailor our treatment regimen according to our treatment goal. If the patient with high tumor load, highly symptomatic, or potentially resectable metastasis, we aim at conversion. We have to use doublet or even triplet plus biologic in order to have achieve maximal shrinkage of the tumor. But on the other hand, if the patient is quite frail or the disease tempo is quite slow and the tumor load is quite small, we can consider using sequential single agent plus or minus biologics. We should also tailor our treatment according to the patient's molecular signature. For the patients with RAS wild type, the patients should use any EGFR. For the patients with RAS mutant, mainly we have to use the bevacizumab. But after the left side and right side story, maybe we should also take into account the sinus of the tumor into our treatment selection. For the major changes is for the patient with all RAS wild type. If the patient carried all RAS wild type in the left side, definitely we should continue to use the anti-EGFR therapy. But for the right side tumor, maybe we should consider more to use bevacizumab. So as you can see nowadays, the management of metastatic colorectal cancer is highly personalized. We would tailor-make our treatment according to the patient's factor and also tumor characteristics like age, performance status. We also tailor our treatment according to tumor load, whether the patient is symptomatic or whether any potential of cure. And lately, we have evidence we should tailor our regimen according to tumor location. For the molecular marker, as Dr. Au has mentioned, we normally in our clinic, mainly the RAS and WAF and also MSI will have impact on our daily management. When you compare back to year 2004, 10 years ago, at that time only one size fit all. It's hard to say at that time we have any factors that will affect our daily management. So you can appreciate in the past decade how astonishing is the advancement in terms of our treatment precision in the management of metastatic colorectal cancer. Apart from the biomarker and individualized approach, another important concept is the continuum of care. We have huge number of agents now available for treatment of metastatic colorectal cancer. 10 years before, we have only 5 used Xeloda, irinotecan, and oxaliplatin, but nowadays we have at least 12 agents. And here's the selected trial, second-line trials. Both the anti-vascular endothelial growth factor like aflibercept, ramucirumab, or continued bevacizumab has implicated in the second-line treatment, and also anti-EGFR therapy like cetuximab and panitumumab has been shown to result modest overall survival and progression-free survival benefit. And in the salvage setting, in refractory cases, we first have the all multi-kinase inhibitor like regorafenib. Later, we have TAS-102. And the recent ASCO, we have another agent called fruquintinib. All results, despite it is a small overall survival benefit, limited response rate, but selected group of the patient will have survival benefit from this agent after exhausting all the conventional therapy. So compared to 10 years before, 10 years ago, the patient only subject to 1 line or 2 line of therapy, but nowadays it's quite common for the patient receive 3 line, 4th line, and even 5th line of therapy. And also the treatment concept is entirely changed. In the past, we're using the treatment concept is entirely changed. In the past, we're using chemotherapy. Usually continue chemotherapy till the patient has disease progression, and then we change another lines of therapy. But our application of chemotherapy nowadays is tailored according to individual clinical condition. If the patient in the induction phase, early phase of the treatment, highly symptomatic, we'll use high intensity treatment. But later, if the patient, the disease becomes stable, we will shift to another low intensity treatment, so-called maintenance therapy, and sometimes even treatment break. But when the disease coming back, we may reintroduce more intensive treatment regimen. So we are now using the chemotherapy in a more continuum of way, and it is more the distinct lines of chemotherapy become less distinct nowadays. So the treatment strategy is now very complex. Treatment sequence is tailor-made according to individual patient. Try to maximize the exposure of different kinds of agent during the treatment course while minimizing the toxicity. We have also very good data that we can retrench the same agent that the patient previously resistant. So we have increased in number of the agents available. We have individualized approach. The concept of continuum of care is widely implemented. all work collectively results significant improvement of overall survival in metastatic colorectal cancer patients in last decade. It's also in terms of treatment precision, there's a dramatic improvement in the past decade. So what's the way to go in the future? We have several novel biomarkers. And in fact, for using a target therapy in metastatic colorectal cancer, although still a lot of room for improvement, we have only two main group of the target therapy: anti-EGFR antibody and anti-vascular endothelial growth factor antibody. Although we are always talking about the EGFR pathway in the management of metastatic colorectal cancer, but we are actually not targeting the mutated EGFR pathway. We are targeting the patient with no EGFR mutation. And also, when we're talking advancing, we are not targeting the specific gene mutation or amplification. We are targeting the microenvironment of the cancer cell. So there's a large unmet need that we have to develop some biomarker or gene specific treatment. So currently only the RAS and MSI and BRAF have approved the therapy, but nowadays there's a more and more exciting biomarker coming to the market, like HER2 and RAS mutation and also emerging target. There's some exciting data coming in past couple of years that may soon impact our daily management. In the last month, FDA granted the accelerated approval to pembrolizumab for first tissue agonistic indication. It's suggesting that for the patient with advanced metastatic malignancy, if the patient was found to have MSI high, they are indicated for pembrolizumab. In the patient who has progressed following the treatment of 5-FU or sulpactin and irinotecan, they are indicated for pembrolizumab. And they are based on the data of Keynote-016. This group of the patients are usually treatment refractory, but if you track the patient with mismatch repair gene deficient MSI high, it's fine that even in salvage setting, the objective response rate is up to 50%. When you compare to conventional salvage therapy like TAS-102 or regorafenib, the treatment response is usually less than 5%. You see it is quite dramatic. It leads to accelerated approval for the FDA to approve the pembrolizumab used in salvage setting. We have tracked May142 data suggesting that nivolumab or nivolumab plus ipilimumab, this combo, also this checkpoint inhibitor also can achieve quite impressive objective response in the salvage setting. So currently there's some ongoing trial that testing the pembrolizumab or pembrolizumab plus chemo in first-line setting. And in the subsequent line per NCCN guideline, we can consider off-label use of pembrolizumab or nivolumab. And per FDA approved, after the patient failed the F5FU or sulpactin or irinotecan, if the patient carry MSI high, it is indicated for pembrolizumab. How about regorafenib? If the patient with BRAF mutation, which is quite common in metastatic melanoma, regorafenib achieved quite a good response rate, but it is not the case for refractory colorectal cancer. We now know that from a Nature published paper, if the patient with BRAF mutation, it will lead to excessive activation of the EGFR pathway. So monotherapy is not useful, not good enough, although it is an essential component. We have to also targeting the upstream EGFR pathway. So the SWAP study is testing this concept. They enroll the BRAF mutated in salvage patient in salvage setting. They are not targeting only the BRAF mutation using the regorafenib. They are also trying to combine it to targeting the upstream anti-EGFR signaling pathway. They compare the standard therapy, cetuximab plus irinotecan. It's fine that it is a positive study. Regorafenib plus cetuximab plus irinotecan is doing better than the cetuximab plus irinotecan. And I want to highlight is that for the BRAF mutated patient, this group of patients really carry quite a poor prognosis. If you use cetuximab plus irinotecan alone, the progression-free survival is only 2 months. So there we have very good data that if the patient with BRAF mutation, we should consider to use FOLFOX3 plus bevacizumab. There's a Lancet Oncology paper suggesting that this combination have an 8-month overall survival benefit compared to FOLFOX3 plus bevacizumab alone. Selected group of the patient with BRAF mutation may have MSI high. This group of the patients we should use checkpoint inhibitor, and in subsequent line maybe we can consider to use the remibrutinib plus cetuximab plus irinotecan. And HER2 for the HER2 mutation. The HERCUS study mainly enroll the patient fail the conventional treatment. It's fine that for they screen around 900 of KRAS wild type patient. It's fine that around 5% of the patient carry HER2 positive. And in the South setting, the combination of trastuzumab and apatinib result overall response rate 30%. It is very impressive in South setting. And similarly, my PARA study also doing this with similar results. So although it is not a standard to test the HER2 and metastatic colorectal cancer, but we should consider HER2-directed therapy if it is detected. So last but not the least, there's also some new biomarkers. But also tumor biology is very dynamic. Liquid biopsy should be indicated to tracking the treatment resistance. And for the sake of time here, come to my conclusion. Recent advance in treatment of metastatic colorectal cancer has significantly improved the outcome of our patient over the past decade. It is a result of improvement of systemic treatment, the individualized approach, and also the concept of continuum of care. Currently, the KRAS, NRAS, BRAF, and also MSI are the molecular markers impact the current standard. We can expect molecular profiling to identify actionable mutation, and also the liquid biopsy could play a more important role in upcoming mCRC management. Thank you for your attention.